Okay, good evening, ladies and gentlemen. Just giving a minute or so for people to join. We'll start shortly. Okay, right. Good evening, ladies and gentlemen. Welcome to tonight's CPD presentation. This presentation is part of a series that is sponsored by Takeda. The topic of this series is Fabry disease. Although Takeda proposed the topic, the content of the presentations is in no way influenced by them. I just like to re-emphasize what I've said in the past. We are trying to utilize the expertise within the audience. The idea is not that we bombard the speaker with questions. So, if you do have expertise, we would certainly like for you to share that expertise with us. So just raise your hand, ask to be promoted to panelist, and then you can join the conversation. And I think that's the thing. It's not a question and answer session. It's really a conversation. With that, I'd like to introduce our speaker tonight, Dr. Ilse de Preez, who has sent me an extremely modest bio, but I read it. Dr. Ilse de Preez is an experienced biochemist specializing in human metabolomics, earning a PhD in biochemistry in 2012. Dr. de Preez is currently the manager of the commercial activities at the National Metabolomics Platform and acting director of the Center for Human Metabolomics. She has supervised several postgraduate students and is actively involved in research and training within the metabolomics field. Dr. de Preez also contributes to national initiatives such as a role as a coordinator for diplomics and involvement in Metabolomics South Africa. And the title of Dr. de Preez's presentation tonight is The Clinical Presentations of Fabry Disease. Ilse, thank you very much, and I look forward to your presentation. Just remember to switch on your
Yes.
speaker.
Good evening, everyone. Sorry about that. If you can't hear me properly, please just put up your hand and let me know. Thank you for joining this evening. I'm going to start off this presentation first with a video. For some reason, my video is not there. I'm sorry. Let's start again.
Don't sweat very well. Stomach aches. Tummy troubles. Unexplainable fevers.
Can't tolerate heat.
Headaches. Pain in my hands.
Tingling in feet.
Corneal whirling.
Burning in my hands and feet.
Miss a lot of school.
Anxiety.
Heart palpitations.
Unable to work.
Being fatigued.
Gastroparesis.
Chest pain.
Gastrointestinal issues.
Migraines.
Kidney disease.
Kidney transplant. Dialysis.
Open heart surgery. Congestive heart failure. Lung issues. Hard to breathe.
Proteinuria.
Hearing aids.
Stroke.
White matter lesions in brain.
Chronic severe fatigue.
A ringing in the ear called tinnitus.
Episodes of pain. Cochlear implant.
Chronic constipation.
a skin rash called angiokeratoma,
edema in the lower legs,
Heat and cold intolerance.
vertigo,
frequent arrhythmias,
left ventricular hypertrophy,
Transient ischemic attack.
peripheral neuropathy,
Raynaud's caused by Fabry disease,
depression,
Heart attacks?
Pacemaker.
Lung disease caused by Fabry disease.
I have 2 sons and a daughter that are all affected with Fabry disease.
My mother, my brother, my daughter, and my aunts and nieces have Fabry disease.
My mother, all of her sisters, and a lot of my cousins also have Fabry.
My father, at the age of 56, passed away with Fabry disease.
I lost my dad at 52 years of age to Fabry's disease. I was 18.
My father had Fabry disease. He passed away at the age of 42.
My younger brother Ken died at the age of 37 from kidney failure caused by Fabry disease. These many common symptoms of Fabry disease vary greatly among individuals. It is invisible, often seen, rarely diagnosed, sometimes called the Great Masquerader. It is far more prevalent than historical estimates indicate, and most importantly, it is treatable. Is Fabry disease hiding in your family? For more information, contact the National Fabry Disease Foundation.
Earlier this year, in February of this year, I was privileged to attend the Rare X conference in Johannesburg. This is a one-of-a-kind conference, and if you've never been there, you should really make a plan and go, even if you only go once in your life, every second year. At this conference, they invite scientists, medical doctors from all different specialities, representatives of medical aid and pharmaceutical industry, patient advocacy groups, but most importantly, they invite patients. And when I started to prepare for this presentation tonight, I kept on thinking about that Rare X experience that I had, and thinking of clinical presentations. It's always easy to think of it as something on paper and something that you read, and something that's theoretical and academic, but I wanted to show you all that video before I started, just to remind you that these are actual patients. These are real people, real children and real parents, and they suffer from these clinical presentations and these symptoms every single day. With that being said, this is not my presentation. This presentation is based on the work done in the late 1800s already by Johannes Fabry and William Anderson. They both described this disease simultaneously, and the disease is also known as alpha-galactosidase A deficiency, Anderson-Fabry disease, which is perhaps a better description, angiokeratoma corpus diffusum, angiokeratoma diffuse, ceramide trihexosidase deficiency, Fabry disease, which is what we commonly refer to it as, GLA deficiency, and hereditary dystopic lipidosis. As Chris mentioned in the introduction, this is part of a whole series of talks about Fabry, and you will see that my presentation is the first and introductory presentation to the topic. So I'm going to really give you an overview of the clinical presentation, perhaps from the eye of the patient, not in much detail, not with a lot of science behind it, because these presentations will come very soon. So we are currently here at the 2nd of October with a clinical presentation of Fabry. Earlier this year, the expert in South Africa, Dr. Wadi, gave the presentation already on the renal presentation of Fabry, and this was a really excellent presentation. If you missed it, it is on our YouTube channel, the recording. Please go and have a look at it. You will not be disappointed. It was really one of the best talks in this whole series. Dr. Wadi was supposed to come later in the series, but due to other obligations, he could not do the talk later. So today is me with the introduction. Next week is Prof. Chris Hendricks with the treatment and management of Fabry. Then Prof. Chris Foster with the cardiac presentations in more detail. Then Marion Gomes, the genetic counseling. Dr. Marley Dabson, the diagnosis of Fabry, where she will again touch on the clinical presentation. Dr. Bertram will go through a case study of a Fabry patient or two, and then Dr. Uma Ramaswamy will go into detail about the neurological presentation in Fabry. I just want to tell you about a previous presentation we also had that's not in this series. It was in a previous series, but it's about the laboratory approach to diagnosing lysosomal storage disorders as a whole. So if you're a lab rat in the audience, please go and watch that presentation if you missed it. This is more lab orientated. Okay, so because this is an introduction, I'm going to show you another video. So I tried to do a quick introduction, but actually it was very difficult for me to beat this one. So this is from Osmosis on the Ilse YouTube channel, and they have loads and loads of similar videos describing different rare diseases and metabolic disorders. If you ever want to explain a metabolic disorder or rare disease to your patient or to your student, or just know about it more yourself in easy terms, please go and watch these videos on this channel. It's really amazing how they put this together. So just to give you a quick overview on the disease, and I'm going to show you this video, and I have to do a disclaimer. There will be an ad. I think when I did the test run, there was an ad before this video. This is from YouTube, because I don't have a YouTube. I think I don't have a paid for YouTube, but you can just ignore the video, please. It's nothing, or the ad. It's not an ad for this presentation.
My skin is perfectly clean, so smooth and hydrated. Switch to the #1 micellar water by Garnier Naturally.
1 in a million. Some say the chance of a planet having the exact conditions for life.
There you go.
Fabry disease is a rare X-linked condition caused by mutations or pathogenic variants in the GLA gene that codes for a lysosomal enzyme called alpha-galactosidase A, or alpha-Gal A. The alpha-Gal enzyme normally breaks down large molecules called globotriaosylceramide, or GL3, and other glycosphingolipids, so that small parts of the big molecules can be recycled for the body to use again. Without alpha-Gal, these GL3 molecules build up inside the lysosomes, the recycling centers of the cells, causing a variety of symptoms and health issues. Fabry disease affects males and females, and it has two forms: classic and non-classic or later onset. In classic Fabry disease, symptoms start in childhood and include burning, tingling, prickling, and painful neuropathic pain in the hands and feet, frequently triggered by exercise, fatigue, stress, or illness. There may also be a gradual decrease in sweating in childhood until many teens and adults stop sweating entirely. In some people living with Fabry disease, small reddish-purple rashes called angiokeratomas appear around the lower abdomen and bathing trunk region of the body. There may also be gastrointestinal symptoms like cramps, frequent bowel movements, constipation, and diarrhea. Many patients have a whorl or verticillata in their cornea that can be found during a split lamp eye exam, but it doesn't typically affect vision. Without treatment, Fabry disease complications can include kidney disease, abnormal heart rhythms, heart enlargement, and an increased stroke risk. Non-classic or later onset Fabry disease doesn't cause the earlier symptoms of pain and gastrointestinal issues in childhood, but some adults develop multiple symptoms as young adults. Others may only show signs of Fabry disease in a specific organ, like the heart or the kidneys. However, these individuals also have a higher risk of Fabry-associated complications. Fabry disease is diagnosed differently depending on sex. For males at risk to have Fabry disease, blood samples can be tested to see the amount of alpha-Gal A. Low alpha-Gal levels prompt analysis of the GLA gene for confirmation. In females, gene analysis should be the first test done, as many affected females have normal levels of alpha-Gal A in their blood. There are 2 FDA-approved treatments for Fabry disease in the United States. Enzyme replacement therapy with a synthetic alpha-galactosidase A called agalsidase beta, and chaperone therapy with megalostat to help enhance residual enzyme activity. Otherwise, treatment is aimed at Fabry disease-associated medical issues, like medications to help with neuropathic pain, depression, and decreasing urine protein levels, or treatments like pacemakers to help with arrhythmias, or a renal transplant for renal failure. Alright, as a quick recap. Fabry disease is an X-linked condition caused by a change in the GLA gene, which leads to a lack of alpha-galactosidase A enzyme. Without this enzyme, large molecules like GL3 build up and cause progressively worsening health issues. Symptoms include burning pain in the hands and feet, angiokeratomas, and decreased sweating. Left untreated, it may cause heart and kidney failure. Early diagnosis through genetic testing is key, and treatment can be done with synthetic alpha-galactosidase A or chaperone therapy with megalostat.
So you'll see if you Google this disease and you start searching for it as if you're a patient and you want to know more about it. So someone once told me, the best expert in the world of any rare disease is the patient who has that rare disease or the parent of the patient who has the disease. So if you start reading about Fabry, most of the information we'll find will be from the USA or Canada, Europe. The reason for this is because we only started really testing for LSDs and Fabry in mid-2019 in South Africa. So we set up the method at the National Metabolomics platform. It's not a genetic method, but it's an enzymatic method, 6-plex LSD. We set the method up in mid-2019, and it is now exactly about 5 years later, and we've had 3,274 referrals. And of those referrals, 1 in every 25 had a positive diagnosis. So we've diagnosed 137 patients with different lysosomal storage disorders. I just want to mention that this test is free to the patients. It's a sponsored test, and if you ever want to test the patient, you can just contact us via the email. So this, what you see on the left, is a screenshot of our website, National Metabolomics platform. If you click on the diagnostic offerings, you'll see the lysosomal storage disorder screening test there. You can read more about the test and how it's done. And you can then inquire now to, if you want to send a sample, you can also contact us via email or via WhatsApp to inquire. We will send the kit to you to get the sample from the patient, to collect the sample, and then arrange for the sample to come to us. This is for state and private patients, and this really changed our view of lysosomal storage disorders in South Africa. Before this time, we had this feeling that these diseases were not really prominent. But if you look at this graph on the right, and I have to thank my colleague Marley Derksen for this, she sent me this just before the presentation, because it actually changed today. Yesterday, believe it or not, we diagnosed a female Fabry patient. So it moved the 13 Fabry patients up to 14. So you'll see that the prevalence is picking up, and as we do more training, the hit rate is also better. So let's go into the general clinical presentations. As I said, I want to do this from a patient's perspective. And if the patient goes and Google Fabry disease because their child or themselves have just been diagnosed, they will get to this website, which is incredible for patients and people with really no clinical background or scientific background. It's called the FabryDiseaseNews.com. And they explain all of these symptoms, treatments, and everything about Fabry in general terms so that you can understand it with a lot of pictures, etc. So I also got this picture from the website, and the picture shows the most common symptoms of Fabry disease. The first of these is neuropathic pain or peripheral neuropathy. And neuropathic pain is a pain due to nerve damage. It is one of the most common symptoms that you see in these patients. More than 2/3 of the patients has neuropathic pain or nerve pain. It is also one of the earliest symptoms. A lot of children with the disease and a lot of older patients as well will go to the doctor initially because of this exact problem. So this is the first symptom that appears. It's a sort of a burning sensation at the tip of your fingers and your feet, hands and feet. Sometimes this sensation can move up to the arms and the legs. It's like a numbness or a tingling, and it's not there all the time. So it's there for a few hours sometimes, or it can last for a few days. And it is aggravated by heat and stress and illness and exercise and other stresses. This is why they also refer to this as the Fabry crisis, when you're in this crisis mode. As I said earlier, Dr. Ramaswamy will give a more in-depth talk on the neurological presentations. But if there's anyone who wants to read more about this from a scientific perspective, there's a great paper that I referenced here, Neuropathy and Pain in Fabry Disease. It's a recent publication, just published in 2024. And this is where I found this beautiful picture explaining the underlying mechanisms of the neuropathic pain. So you could, if you wanted to read up more about the detail of that before the presentation, this is a good reference for you. Then going to the eye symptoms. In these patients, we do see corneal ventriculata. So this is very, very unique to these patients. It almost looked like there's a cloud area in the eye. And interestingly enough, these patients do not complain about any visual loss. They don't see anything weird. They don't have any pain or discomfort in the eye. And I've read that some of them actually see a little green or a bluish dot, but this is very rare. The reason for this cloudy surface is the buildup of the GB3 in the eye. And you can unfortunately only see this with a slit lamp examination. In the introduction video, I realized that the guy said split lamp. It's not split lamp, it's slit lamp. So if you see this in an examination, or if you see this in your optometrist examination, test for Fabry immediately. You sometimes do find this in other disorders, and when you take certain drugs that also build up in the eye, but this is quite rare. This is sort of a dead giveaway. The chances are super high if you see this, that this patient will have Fabry. Immediately test for Fabry if you see this. There's also other eye symptoms that's not as prevalent as the ventriculata, like cataracts, optic nerve atrophy, or conjunctival basal tortuosity. In basic terms, it means that it's a twisted blood vessel in the eye. You can see this picture of an eye where you see this twisted veins. It's because of the blood flow and the damage to the blood vessels. So it looks like a twisted vein in the eye. Then I want to just direct you again to another publication if you want to read up on this specifically. So just to get to this publication, in 2001, the Fabry outcome survey was started. And this is basically a repository, currently has 4,500 Fabry patients in this repository, and they follow these patients year by year with a lot of detail. 5 years since the start of the survey, they brought out the entire book about this, and each chapter is specific detail of a specific thing about the disease. It's now 20 years later, and I see that there's a recent publication also. So they constantly update this. So the most recent publication is now the 20 years since the Fabry outcome survey. Chapter 26, there's a link, is about the ophthalmological manifestations of Fabry disease. So if you really want to go more into this, read about it, but I'm sure in the neurological talk, you'll also hear a bit more about this. Okay, then something that I added that's not on this website as a general symptom, because it is not really that a giveaway, it's not that unique to Fabry, is the facial features. You can't really use the facial features as a diagnostic tool because it's not that unique, as I said, but I wanted to show you just how someone with Fabry looks and discuss the facial features very quickly. So these people normally have puffy eyes, puffiness around the eye socket, so they're below the eye. It's a fullness of the periorbital area. And like what you get when you're a bit tired or have allergies. They have a pronounced nose and ear, but from the initial video, I think you would agree with me that you can't really see something like a pronounced ear and nose that stands out. Recessed forehead, so the forehead is slightly leaning backwards. A prominent brow bone, so this is the bone supraorbital ridge, so this is the bone behind your eyebrows, slightly prominent. Bushy eyebrows, again, full lips, it's not unique features. I just wanted to show you some of the features for interest's sake. The reason, sorry about the blurriness of this picture, but I wanted to include this specific picture because I also found a very interesting publication on the facial features of lysosomal storage disorders. Also a relatively new paper, and you can do yourself a favor if you're interested in these things, but there's a lot of photos in this publication where they show you pictures of all types of lysosomal storage disorders in all types of patients. And this picture is the Fabry patient in this publication, which is why it's so blurry, but I think you get the picture. Okay, then going back to the most general and common symptoms of Fabry is the skin features. And another dead giveaway, like the ventriculata, is the angiokeratomas. This is also a very, very common symptom. Most of the patients has this. It's small clusters of red spots. These red spots are very hard. The top picture is zoomed in, so you can see it's a round, hard, wart-like type of spot. It's because, again, of the dilated blood vessels. Luckily, this is benign. It's not cancerous. It's not painful. But if you scratch it or bump it, it can easily bruise and bleed. You typically see this feature between the navel and the knees in the swimming, bathing area. What did the initial guy say? In the bathing area of the body. But sometimes it can also move to the lips and the hands and the feet in rare occasions. This presentation and these dots do increase in number and in size as the disease progresses, in other words, as you age. You also find hyperkeratosis in some of these patients. It's not as obvious or as common as the angiokeratomas, but this is a thickening of the outer layers of the skin, resulting in a dry, itchy patch. So if you see verticulata and angiokeratomas, immediately test for Fabry. Also in that outcome survey book, chapter 24, you will find a lot of dermatological and soft tissue manifestations of Fabry disease in much more detail. Okay, then the sweating issues. You heard a lot of the kids in the initial video said that they cannot sweat, they're always hot. So these patients suffer from hypohidrosis or anhidrosis, which is less sweating or no sweating. This is due to damage to the sweat glands, but also damage to the nerves. The nerves that has these autonomous features or functions. So all the actions that you do not willingly do, like sweating, those nerves get damaged. These patients therefore easily overheat, they easily get fever, they're intolerant to extreme temperature, and interestingly enough, not just to heat, but also intolerant to cold. And they have exercise intolerance. If you have a late onset patient, you would sometimes find that if you ask them if they did any sport as a child, they would say no, they didn't do any sport because it was just not something that they liked, or they were overheating or whatever. They never really did sport. In some patients, very rare, you do find hyperhidrosis, which is excessive sweating, but it's not really that common in these patients. It's in only a few cases where it's been described. Now, the sweating issue and the fact that they don't sweat is actually such a big thing to these kids that there's an entire website dedicated to this. It's called Cool Down Fabry. And it's also a very, very great resource to use and to give to your patients if they need some information, because there's a lot of patient stories and videos on this website. There's a lot of patient advocacy groups that they can join, newsletters up to date, and so on. All right, let's move to the gastrointestinal issues. You can recall from the patients that also said a lot of them had diarrhea, abdominal pain, mucosal lesions, intestinal malabsorption, bloating, and fullness. And also in this outcome survey, chapter 28, they go into detail about this, but I wanted to show you one of the outcomes, which is quite interesting. So just as an explanation, on the y-axis of all of these graphs is the number of patients without symptoms. So if it's at 100%, it means that none of these patients had this specific symptom. On the x-axis, you have the age. So at which age did they have which symptom? And then each graph is a different symptom. A is diarrhea, B is abdominal pain, C is hemorrhoids, and B is constipation. So interestingly, you'll see it's actually not that clear, but the darker line is the female line. So the black line, and then the gray is the males. What this shows you is that diarrhea, as time progresses and the disease progresses and age progresses, diarrhea becomes more prevalent in more patients. So at between 0 and 10 years of age, almost none of the patients had diarrhea, but then at say 70 years old, 80% of the males had diarrhea, but only about 60% or 50% of the females had diarrhea. So this shows that even though the symptoms is in males and females, it's much more prevalent in the male patient group. So only a few of almost half of the females showed this. This is also the same for stomach pain. And then another interesting thing is if you look at the top or the bottom graphs, you'll see that generally less of the patients suffer from hemorrhoids and constipation compared to diarrhea and tummy aches. And the difference between the males and the females are not that distinct. And what the authors here mention is that they still don't really know if this is specific to Fabry and the progression of Fabry, or if it's just a general aging symptom, if it's just something that happens to people when they get older. Some people, as you can see there in the female population, it's about only 30% of them saying they had hemorrhoids and constipation. So is that just a normal population thing, or is it related to Fabry? They don't know. But the point is, these patients do have gastrointestinal issues, but diarrhea is much more prevalent than constipation, and it's also worse in men compared to the ladies. You can also read up on chapter 28 of the book. Okay, then the kidney problems, as I mentioned earlier, you should really go and watch the presentation of Dr. Wadi on our YouTube channel if you haven't yet. If you have, then you would know that I'm just touching the surface here. So kidney problems eventually develop. It's not the first symptom, and the reason for this is it's the build-up of GB3 that leads to the kidney problems that you eventually see. It worsens over time, so as the disease progresses and you grow older, the kidney problems will also continue to get worse. You would then get kidney failure, which includes muscle cramps, edema, dry skin, changes in appetite and urinary frequency. Although this is not unique to Fabry, this is kidney failure symptoms. So while most of the children will present first with neuropathic pain and go to the doctor because of that, more adult onset patients will go to the doctor initially because of kidney problems and kidney issues. And Dr. Wadi also mentioned, that they see a lot of these kidney patients, and then only after lots of investigations, they actually start doing the Fabry testing. Okay. Similar to the kidneys, the heart is also a symptom that heart disease is also something that progresses over time because of the accumulation of GB3. So not always seen in kids, more later in life. You see symptoms like left ventricular hypertrophy, which means that the left ventricle enlarges and thickens, and then the heart struggles to pump the blood through the veins. So it's difficult to do its job. You get malfunction in heart valves, arrhythmias, which is irregular heartbeat, high blood pressure due to the heart working so hard and not properly working, eventually heart failure and a heart attack. I'm also not going to go into this very deeply because Chris Foster is the one who will present the cardiac presentations in detail, showing you all the interesting mechanisms and things behind that. Also, recent publication, if you really can't wait until the 16th of October, then you can go and read this publication in Cells, Fabry Cardiomyopathy, Current Practice and Future Directions. A very interesting paper. Okay, so we went through all the typical features that you would see, but remember, this is a multi-organ, multi-system disease because of the buildup of GB3 everywhere. And you do get a lot of these symptoms that's unique. And as we initially heard, that every single patient with Fabry is unique. It's rare that you get two patients that shows you exactly the same symptoms. And so there's less frequent symptoms associated with Fabry, such as on the left there, tinnitus, which is a ringing in the ear, sometimes slight deafness, or stroke or a mini stroke, breathing difficulties, anorexia. Anorexia could maybe be as a result of the gastrointestinal problems that these people have, and they really don't want to eat. And then breathing difficulties, persistent cough, chronic fatigue, anemia, sparse hair growth, delayed puberty, and anxiety. I found another interesting website. So this website part is from the Genetic and Rare Diseases Information Center, and it's from the NIH, and it's not just for Fabry. So this is for all rare diseases that you want to see, and it doesn't just give symptoms, it gives a lot of other information about these rare diseases. But this can be a guide for physicians if you needed some type of guidance. So if you're not quite sure, you can always go to this. And the nice thing about this website is it gives you all the symptoms, and you'll see there under Fabry, it listed 59 symptoms, much more than I spoke about tonight. But it will also give you the frequency. So for example, in Fabry, anemia is quite frequent, where angina pectoris or chest pain is seen in some patients, but only occasional. Angiokeratoma, very frequent. So if you wanted to look at that, it will give you indication if the symptom has in the past been associated with Fabry or any other rare disease for that matter. Okay, this is another interesting paper, and this was sent to me by my co-host, Chris Foster. So this is Fabry scan, and what is very unique about this is not a bedside diagnostic tool or a point of care test or whatever. This is not a physical test, this is a questionnaire. So these guys try to come up with a set of questions that you can use to diagnose a Fabry patient. And what they did is they set up about 15 questions. And for each question, you can then, as a patient, say it's absolutely correct, fairly true, not true, and most definitely not. And you then get a score for each of those answers, 1, 2, 3, 4. And then at the end of the questionnaire, they will sum your answers and your scores. And if your sum is above a certain number, then they will say they predict that you have Fabry. So they had 15 questions initially. They did a lot of statistics on that and p-values and fancy things. And they came up with a list of 10 questions. So 5 of these questions didn't really contribute to a diagnosis, but 10 of them really did contribute. And these are the ones in bold there. And they said that if they ask these questions to patients, and okay, they didn't ask the question to just anyone out there. They asked the question specifically to patients with peripheral neuropathy. So if they had this nerve pain, they asked them these questions, and they could, with these questions, correctly identify 76% of the patients with Fabry, the sensitivity of 88%, and specificity of 87%. I'm just going to read you some of these questions in bold. So question 3, for example, compared with others in the same situation, do you sweat less or even not at all? Have you ever noticed small spots of reddening on the skin or on the pelvis? Do the symptoms of pain occur in high outdoor temperatures? So this is a nice tool for you to use. And if you need to use this, it's completely free. It's a publication. You can download the publication, you can use it. So it's not something that you need to buy or learn how to use. It's very easy. Okay, I added this video at the end of a patient again, just to also end off with the patient story. I see I do have some time left, so I'm going to show you this video. And after the video, you're welcome to ask questions. You can type your questions in the Q&A tab or in the chat box, and I'll try my best to answer. As I said, I also have Prof. Chris as a co-host. Please don't ask the very difficult questions. Keep that for the very difficult talks. Okay, so let's watch this last video.
My name is Ed, and I was diagnosed with Fabry disease in 2001. I learned that the life expectancy for a male Fabry patient is 50, and I was 43 at the time, so I don't know if this is real or not. Fabry disease is a very rare, life-threatening genetic storage disorder. We're missing a key enzyme. It affects all the fine blood vessels in your organs.
I got the call from his kidney specialist that the biopsy showed up that he had Fabry's disease. Never heard of it. And that really started us all on a journey. I told my mother-in-law, and she contacted her sister in the Netherlands, and her sister knew of a cousin who'd had the disease. So that started the whole, okay, this is hereditary, who's had it, that sort of thing.
Everybody in our family got tested, and I have 2 brothers, and they got tested, and one of them has Fabry and one of them doesn't.
When Ed was diagnosed, I thought, this doesn't sound abnormal, this sounds like me, exactly. I mentioned the illness to my doctor, and his response was, I think I remember reading about that in my textbooks when I was studying, but he'd never had a patient.
It's a very, very rare disease. I think there's only 500 patients in all of Canada today that have Fabry disease, so you can't expect people to know about it. Knowing about Fabry disease sort of answered a lot of questions that I had because some of the first symptoms occurred when I was like 4 or 5 years old. When it was warm out and we used to play and run, and the feeling I would get in my hands and feet were like they were on fire.
Ed had a real love and passion for playing sports and enjoying life that way, but his stamina and ability to partake was always limited because he just had trouble perspiring, no real stamina or strength to do some of the things that I could kind of do naturally.
My brother stepped up and donated one of his kidneys to me, and that's life-changing. It was just awesome.
I think the decision really to become a donor was really bottom line to make a difference in Ed's life. And I think I was kind of jogging maybe 3-4 weeks later. So it really, really went well. I've been able to maintain the lifestyle that I always dreamed I would be able to have.
When I got out of that hospital after my transplant, I felt I was resurrected. Man, I never felt so good in my entire life. Past 18 to 20 years have been a real roller coaster. From a physical standpoint, you never know what's coming. But from an emotional, psychological perspective, it's taught me a lot. And my purpose in life is to bring hope and encouragement for other people.
These days we spend our winters down in Arizona. When we come now, and I think 2 years ago was when I really saw the benefit in Ed's health by coming down here. And this year when we came in October, he hadn't been very well before we came. Give him 10 days down here and he's looking fine again. My advice for somebody who is a caregiver, a spouse of someone with a life-threatening illness, don't be afraid to ask others who might be doing something similar to say, how do you cope with this, or how are you coping with that? And that's been helpful as well.
One of the things we're all trying to do is find Fabry patients, because at the end of the day, we want Fabry patients to be diagnosed. We don't want them to have to spend 43 years in the dark. We want them to be diagnosed, and we want them to be treated accordingly. The sooner you start treatment, the better off you're going to be with Fabry's disease. There are some fantastic experts out there who make it their mission and lives to help people like me. You can overcome any challenge, including living with Fabry's disease. My name is Ed.
So, yeah, I hope that brought back, you know, what you need to know about the patients. And I hope that you learned something tonight about the basic clinical presentation. Thank you for joining this evening. And then please remember to attend the upcoming talks that will be in much more detail. Next week, Prof. Chris Hendricks, and then every Wednesday after that. Thank you very much. You're welcome to now ask some questions. If you wanted to be unmuted, just put up your hand and we can unmute you, and you can then talk to the panel. If you've ever seen a patient like this, please put up your hand and tell us about it. Yes. Thank you, Chris. You can continue.
Thank you, Ilse. Thank you for a very nice presentation. I think sometimes we rush through these symptoms very quickly, particularly if you're from the lab. And I've certainly learned a couple of things about more detail about and specifics about the clinical presentation of Fabry disease, and also some interesting rare symptoms and signs that I didn't know about. So thank you very much for that. There's currently no questions that have been posted. So maybe I can start off with one directed to you and the audience. So I recently, I think I read that the incidence of autoimmune diseases is higher in female Fabry patients. And I wonder if you picked up something like that. Or I see Chris Hendricks has got his hand up. Let me just see how he would certainly know.
Can you hear me?
Yes, we can hear you, Chris.
Yeah, so it's one of those things which is definitely coming more and more out, but it's very hard to say if it's a direct correlation or just because those patients has got so much overlap. A lot of them end up being tested for autoimmune diseases first, and then the Fabry diagnosis is coming later. So I think you've got an ascertainment bias, and because a lot of patients actually have it. So I think I'm not sure if it's completely real that there's an increase, but then the latest data, as everybody will know, that COVID is now associated with a much higher incidence of autoimmune disease, either disease or immunization, both of them. So I think we're just learning more. So I think that's the first thing about autoimmune. I just wanted to make a comment as well. Many years ago, it shows how awful we were to our patients. I was listening to you, Ilse. We had something called a cold immersion test. I don't know if people still remember that. We used to make a bucket full of ice water, and then you ask the patients to put their arms in there. And if they could last 5 minutes, they did not have Fabry, or there was a few other conditions where you've got cold intolerance. And I can still remember we did this for Fabry disease many years ago. But it was interesting, and you do wonder if you've got nothing else, if it's still a good test in some places. Because what we found was that most of the Fabry patients could last only about 90 seconds, because the intense cold caused by ice water, they just cannot tolerate it. They would just yank their arms out. So it's not a validated lab test for anybody listening, but it was just an interesting thought. And it did show us the intolerance. And then lastly, one more comment. I think it's just for perspective. One of my Fabry patients I had diarrhea. So she was a female patient, so actually everything against what is published. But to put it in context, she had an average of 30 stools per day. That means if you're awake for 15 to 16 hours, you have a diarrhea stool twice every hour. So she couldn't get the kids to school or anything like that. So those can be quite disabling. But also, she was just told that she's got a psychosomatic disease and she's making herself go, and was consuming huge amounts of loperamide to try and control it. So just another thing. And I do think it's important we do think about Fabry, because there should be much more patients in South Africa than what we're seeing at the moment.
Yeah, I certainly agree. I think, we are diagnosing an order of magnitude less than what we should be diagnosing. Just in terms of that ice bucket test, is that not also a way in which you can distinguish between Fabry and erythromelalgia? I think the erythromelalgia patients, they get better when they put their hands and feet in ice water.
Yes, it is. And I mean, it's an actual test. There's quite a few publications, I think, in the kind of mid-2000s, people talk about the cold immersion test and things. But the Fabry patients has got the shortest cold immersion tolerance. Although, like I say, it's not validated, but it's something we did use, and it was very good. And we actually used it for the kids. So when you've got siblings and you've got events for families, you want to get the siblings to try and understand what the sibling is going through, because this can be quite disabling. So when they see that you know how competitive siblings are, and if they see that their sibling can only last 60, 70 seconds, but they could easily do 3-4 minutes in the ice water, it gives them a real sense, actually, of how disabling this heat and cold tolerance can be for patients.
Okay, we do have a question from Monique Opperman. Can someone who suspects that they may have a specific condition pursue testing, especially if their doctor has already run multiple tests but hasn't been able to determine what's wrong? If the patient has done further research themselves and recognizes many of the more unique symptoms, are there alternative ways to request testing or seek a diagnosis outside of the traditional doctor's route? Or will you rather discuss this with the doctor specifically and request a test through them? And she says, well, specifically Fabry in this case. Ilse, you want to answer?
Yeah, so we normally accept, this is a difficult one because we can't really just test you if you're the patient. You need to go through a clinician. And I think if you are the patient and you are sort of certain that you want to be tested for this and you cannot find a doctor who wants to test you for this, then you can contact us and we can help you find a doctor who can help you do the test. So Monique, yes, please contact us and we can put you in contact with a doctor who understands Fabry and maybe do a proper clinical investigation first and then suggest the test.
I will chip in there if I'm allowed. I would definitely say find another doctor rather than getting involved in that. And I'm not sure how many of you are aware of 23andMe, which is where patients can send their own samples to local laboratories in Europe and they get genetic testing. It's causing huge issues for many of us in the medical profession. And it just shows again that you need to trust your doctor and get them to do the tests. And if they are not responsive, try and find another doctor or a second opinion.
Yes.
Yeah, absolutely. Ilse Ansi Mini is saying, great presentation. I don't see any other questions. Are there any other comments from anyone? Chris, you have any final remarks? How do we diagnose more Oh, Ilse, while you were presenting, I asked ChatGTP. I said, I have painful hands and feet. So what's my diagnosis? And it listed a couple of things, but it didn't mention Fabry. So it seems like there's still a lot of education that's required also for AI. So, Chris, how do we increase awareness with Fabry? I know also from the lab side, we actually get a lot of referrals for Fabry testing, but the diagnostic rate's actually fairly low, maybe because the symptoms are so non-specific. As I also get the feeling that, there's still more education needed to actually alert people to this, and maybe not just clinicians, but also patients. So you have any final words on that?
Yeah, the first thing I would say is firstly, hand pain in children is never normal. And I don't get me started. I can start rambling down multiple conditions. So if you find a child with pain in their hands and feet, that is always abnormal and you need to keep on looking. And that's where a lot of our children were missed with Fabry disease. And then, of course, the really important is the role of genetics and genetic counselors. Once you find the first patient, it's incredibly important to really look for those patients through the families. Because, like I say, if you think that, I just heard there they've got 500 patients in Canada. We had nearly 500 patients just in Manchester with Fabry disease. But that was all from family screening. Once you find one, you find multiple others. So that's the really thing. You really need your genetics sorted out. And I think the other thing as well is we miss the females. I think we're all still stuck in the mindset that this is a male disease. And because it's so non-specific and the diagnosis is so complex in the men, people tend to miss it. But that's why I say, if you find somebody you suspect, try and find a man in the family. And it's old-fashioned medicine. Take a good family history. Did the uncle die of heart disease, kidney failure, all of these kind of things? We've forgotten what old-fashioned medicine looked like, where you actually take a decent family history and a social history and everything else, and then it comes out. So I think we need to become better doctors again, where we actually have histories and things like that, but then we also need to be better communicators. And that's where I will keep on saying, speak to the lab, speak to the other people, involve them, and get their advice, get the correct samples and things tested. And don't stop testing because you don't find a patient. I just today found a paper which you may have seen about, which was published about 4 or 5 years ago. Oslem Gokal in the USA has looked at all of the African samples. She got about 3,500 patients from African descent and ran them for lysosomal storage disorders. And she found that actually there was just as many Fabry as there was Gaucher in that cohort of 3,500. So for each Gaucher, you should have a Fabry. So even if you're under testing, you should have at least 44, if I remember your numbers correctly, at least 44 Fabry patients to back that up. So it tells you they are being missed. And I think in South Africa, they most probably missed in cardiac clinics. I would most probably think the majority are missed in the cardiac clinic.
Yes,
Okay,
if I can just comment on that. I just want to comment on that. I think we try to do as much training as we can to the clinicians, but in this case, a patient can either be a child or an adult. A patient can either go to a cardiologist, a nephrologist, a neurologist. So it's very difficult to target a specific group of physicians to do the training for Fabry. I don't know if I'm wrong there, but I would like if someone from the audience or can just give me some input on where do most of these patients actually go to? Because I couldn't deduct that from my search. I see there's a hand up. Oh no, not anymore.
There's a question. It was interesting to see that stroke was one of the less frequent symptoms. If a neurologist sees a young patient with an unexplained stroke, would you suggest that they test for Fabry disease, especially if they have some of the other Fabry symptoms, but the stroke is the first presenting symptoms?
Yes.
Yeah, absolutely.
And I could add there as well, if you get an MR angiogram, I don't know if they're available, if you've got vertebrobasilar changes it's highly suspicious of Fabry disease. I'm sure Uma will be talking at the end of the month and the neurological time, but there's very classical changes in the vertebrobasilar vessels. So that's the important thing. And if you talk about young persons with stroke, please don't forget about homocystinuria. It's just as important as Fabry.
Bertram, you...
Thanks very much, Chris. Thanks, Ilse. It was a lovely overview. That I think the one thing that should be stressed is the multi-system nature. And as you were saying, they end up with specialists, and the specialists don't notice or don't actually take note of the multi-system involvement. And the other important thing with Fabry is it's progressive. And if you've got the progressive and you've got the multi-system and you think a bit further, I'm sure you'll get to the Fabry as well.
Yeah, I agree with you. I think, one of the problems with specialization is you only look at your system, right? Actually, the only people that still look in a multi-system way are the GPs, so maybe we haven't done enough training amongst the GPs. I think the general pediatricians are better trained, but our GPs certainly, that may be some area where we need to focus. Okay, I've got no other questions. Ilse, thank you for a great presentation. And we look forward to the other presentations in the series. To the audience, thank you for attending. And we'll see you next week, same time, same place. Enjoy your evening and good night.
Thank you, everyone. Good night.